Well, good evening and hello all. I hope all of you are safe and at good health, right? So, actually, in the previous month, when I was taking some YouTube sessions, I had a feedback from some of the learners that you all want small topics which are often missed out while we are doing the systems and or we are doing the major part of a particular subject. So that gave me the idea of coming up with this essential short topics in pediatric series. And in the last pediatric I took up nephrotic syndrome, so that was a pretty good response where we had a one-to-one interaction discussion about the whole topic and a very good MCQ discussion as well. So we had discussed pretty many MCQs in the previous topic. So today I have come up with a new topic for you all, that is congenital infections. So this half an hour I'm going to take the torch. I'm going to begin up with the torch and I'll be taking toxoplasmosis as a first topic of discussion. As far as this congenital infection is concerned, the problem with these short topics are that we don't have the relevant literature with us that will help us to crack the MCQs related to the particular topic. So I have come up with all the relevant information, easy tricks to remember without getting confused, and some basic fundas that will help you in solving the MCQs related to these particular topics. Okay, so let's begin up. So just a brief introduction of what we do in an academy. So you all know that we have a very good academic sessions in an academy. You can learn live from the home itself. You don't have to travel anywhere. So actually, truly speaking, this lockdown is not affecting anybody, especially the learners of an academy. You can have unlimited access to all the courses, like all 19 subjects on your screen, on your desktop. You can just open them and go through them at any time. There are so many practice tests going on and off. Then plus every educator, whatever PDF they upload during taking the lectures, you can get those as your study materials. So you get ready-made notes as well in PDF format. And there are many upcoming batch courses which keep on coming depending on which examination is about to come and so on. Plus there are one-to-one interaction, that is you can directly contact us through an academy and get your doubts cleared if at all I'm not there on live. Okay, so these are all the benefits of an academy. Secondly, we are just like covering, there's exhaustive coverage of the syllabus. After every third session we have the routine doubt clearing session. So these are all the benefits of an academy plus platform, in addition to the live test series as well. So that's a good introduction about the an academy plus. So let me begin up with the congenital infections. Okay, so these are some of the list of congenital and perinatal infections to begin with. I believe all of you must be very well aware of this. Now coming to the next, that is the first, the congenital infection, that is toxoplasmosis. Okay, now just to begin with, okay, so this toxo, easy way to remember most of the portion of toxo. Okay, a simple mnemonic, which of course I have not come up with this mnemonic. It is a very good teaching mnemonic. So if you see this whole word toxoplasmosis and you write it as, okay, I'll just write it over here, toxo, okay, P. So this is toxoplasmosis. Now I'll show why I wrote the whole thing. Okay, so if you join this T and P, okay, you get a phase like, right? So this signifies that there is an ophthalmic involvement which suggests chorioretinitis. Okay, and this huge head, okay, the broad head itself suggests that there is an element of hydrocephalus. Okay. In addition to this, there are some intracranial calcifications. So this is the hair portion. So these are the calcifications. So these are the typical three features, classical three features of toxoplasmosis. So the intracranial calcifications, chorioretinitis and hydrocephalus, right? Now come to this P. Okay, so this P means pregnancy. So the main presentation of toxoplasmosis during pregnancy is lymphadenopathy. So most of the high yield points which I am going to discuss in my upcoming slides are actually hidden in the word itself. Okay, right. Fine. And that's it. Okay, so and mostly it is through the transplacental infection. So P again stands for placental. So that's the toxoplasma facies, and in addition to some important MCQ points that is hidden in the name itself. So now let us begin with toxoplasmosis. As I told you, okay, you all know that mostly it is from the protozoan, that is Toxoplasma gondii. Okay, and the cat is the definitive host, right? So in the previous phases, if you add this M over here, so it actually resembles a cat, right? So a typical cat. Okay, so birds, mammals, humans are intermediate hosts. And coming to the infections, so I told you they are mostly placental, transplacental. But how does the mother get infected over here? It is either by it's mostly through the cats, ingestion of the tissue cyst which may be present in the meat or the garden products, and contact with the oocytes in the fecals. Okay. Now the next point is here, which we have already discussed, that most of the time the maternal infections are asymptomatic. So this word is very important over here, and if at all they have to present up, so adults mostly they will present as lymphadenopathy. Okay, so isolated presentation can be only lymphadenopathy. That is one very important thing to remember. The next point, now see this, what I have mentioned over here. You can see some percentages given over here. Okay, don't get worried when you see these percentages. I'll make it very simple for you. See, what I have stated over here is the risk of fetal infection. So now we have first, second and third trimester. The risk of a fetus getting infected in the first trimester is very less, and the risk of the fetus getting infected at third trimester is max, that is 65%. But the seriousness of the risk is inversely proportional. Okay, now if the infection has, or the fetal infection has occurred in the first trimester itself, that's the most serious infection. Okay, and here mostly it is death or abortion. Okay, they don't survive. Now, and if the third trimester the fetus is infected, so 90% of the newborns will be born without actually any clinical signs of the disease. So that is exactly what I've told in this with this red highlighted words, that is infection rate is higher with infection in third trimester, that is the 65%, but a fetal death is higher in infection in first trimester. Is that clear? Okay. Now coming to the clinical manifestation, so few of these words are going to be repetitions for you, but you need to understand the depths of the terminologies which I am using over here. The first thing is, I just told you that 70 to 90% of children are asymptomatic at birth. Okay, so that's the most important point. Even same for the pregnant ladies also, most of the time they are asymptomatic and hence often missed out. Except for lymphadenopathy, there is no other features, right? Now See, there are three things I'm going to tell you over here, but ultimately the answer will be chorioretinitis. Okay, now that means three more MCQs. The first word is that more than 50% of congenital infected infants are considered normal in perinatal period. So, a congenitally infected child who is born normal can develop ophthalmic or the ocular manifestations, that is chorioretinitis, in the later stage of infancy. Okay, this is condition 1. Okay, the next condition is all congenitally infected individuals who do not manifest any signs or symptoms of infection can develop chorioretinitis, and definitely they will develop chorioretinitis by adolescence. This is second MCQ for you all. And third but similar, all asymptomatic infants, okay, initially all asymptomatic infants but actually infected can develop chorioretinitis in the later half. So you see, all three sentences are framed differently, but ultimately the question that they can ask you is whether they can develop chorioretinitis or not. The answer is yes. Whether the child is infected and asymptomatic or is absolutely normal even till the infancy stage, or is without any high risk, in that all these three scenarios the child can develop chorioretinitis if the child is infected, okay, at the time of gestation. Okay, so now hello Dr. Shrinu and Dr. Rahul Soni. Okay, so we are discussing TORCH group of infections. I've just started off with toxoplasmosis. We had some interesting diagram in the beginning just to remember the important points in toxoplasmosis. So okay, and this is the triad which I was talking about in the diagram itself. So just I'll repeat the diagram over here. That's a huge head. What I did was I wrote toxo, okay, and I joined T and P. So these are the two eyes, okay. Plasmosis ka M comes over here, and those becomes the ears of the cat. So the relevance is the cat is the main host over here, and the chorioretinitis over here, and huge head, that is hydrocephalus, and some hair over here, that is intracranial calcifications. Okay, so that's quite simple. Right, now coming to the other features. So just remember that few features are common for all the cases, the congenital infections. So we just need to remember them roughly. Like over here we need to remember that they can develop HS megali, okay, HS megali with some can develop microcephaly also. And lymphadenopathy is most important in addition to seizures, jaundice and thrombocytopenia. Okay, now coming to the severe form of toxoplasmosis. Likely we can see severe form of toxoplasmosis in three cases. First, in the immunocompromised individuals who are HIV positive, in the developing fetus. So that is during the first trimester, okay, and in healthy individuals where they are on some or the other forms of immunosuppressive agents. Okay, so these are the three conditions where they can develop severe disease. You can see this ring enhancing lesion. This ring enhancing lesions can cause encephalitis to begin with, and this is more commonly seen in immunocompromised host. Okay, don't get mixed up with neurocysticercosis, because they will also look similar, but you can just see the shape. See, neurocysticercosis will also have a ring enhancing lesion, but you can very typically see two scolices inside, right? These two dots will look like the scolices, whereas here you can't see those scolices. So that is how you can differentiate between the CT scans of these two lesions. So this is how a huge hydrocephalus in a child. You can see the exceptionally large head, the sutural separation and prominent veins on the head, and in addition to that you can see here there is a chorioretinitis, right? Okay. Now coming to the diagnosis, see there are two modalities of diagnosis. One is either you trace the IgM antibodies, okay, or you go ahead with the IgG. Now IgM means acute infection. The child has got acute infection, okay. So for IgM we have this positive IgM ELISA and IgM ISACA, that is immunosorbent agglutination assay, which results in diagnosis of congenital toxoplasmosis. And the second is either persistent or rising titers of IgG in the dye. Now suppose acutely you have not diagnosed a case, you are suspecting a case of toxoplasmosis, okay. So what you can do is you can get the series of IgG titers done. If the IgG titers are on increasing trend, you can actually realize that this is a case of a toxoplasmosis and an infection is going on. So we need to treat it, because without treatment, if this patient goes, then definitely this patient will develop a complication of chorioretinitis. That is not good enough. Okay, so some countries have already started up this neonatal screening, that is they use IgM over here. Now you know acute infection, so IgM titers are important. Now coming to the treatment portion. So treatment, prevention and treatment goes hand in hand, right? So prevention and treatment goes hand in hand. Now coming to the first thing. So in a pregnant mother, what would you do? So first of all, if you are sure that the fetus is not get infected, so we have two things over here to remember, that if to prevent the infection in the fetus, okay, so we are targeting the fetus only over here in a pregnant woman. So to prevent the infection, first thing, and the second thing is if the fetus is already infected, now what are we going to do? Okay, so in the first scenario, that the mother has been diagnosed as a case of toxo, but the fetus is not yet infected. So to prevent this infection, we will start up with spiramycin. Okay, as simple as it is, no confusion. Okay, now coming to the next thing, that is the mother has got toxo and now here the fetus is already infected. So we have to treat targeted therapy. Okay, we have to give targeted therapy. So we will give three things over here. First is this one, pyrimethamine, okay, and to counteract this pyrimethamine we will give leucovorin, correct, and the second drug is sulfadiazine. Okay, so these are the three drugs which we have to give. These are the other roles of pyrimethamine also, right, and leucovorin is like a rescue therapy for pyrimethamine. If suppose in the first trimester the mother has been detected as a case of toxo and the child is also positive or the fetus is also positive, okay, or there's a chances that there is a probable infection in the fetus, we would generally avoid pyrimethamine and rather directly give sulfadiazine. Why? Because pyrimethamine is a potent teratogenic drug. So this is one more important thing. So very simple, this slide first is to prevent infection in the children, in the fetus. If the fetus is spared, still you just give pyrimethamine. If the fetus is already infected, you are giving pyrimethamine, sulfadiazine and leucovorin as a rescue therapy for pyrimethamine. That's clear as that. Now two very important statements over here, that is treatment of the mother of an infected fetus with pyrimethamine and sulfadiazine reduces the infection in the placenta and the severity of the disease in the newborn. This is one thing very important. Okay, write it down. If you don't have it, this information with you, just write it down because this is very important. And as I told you previously that during the first trimester we generally avoid pyrimethamine because it is a very potent teratogenic drug. Okay, we would definitely not like to give them. So the only drug that we give is sulfadiazine. Okay, now interestingly, suppose the child has come out and we have documented a positive IgM titer. or we see that the IgG is, or the child has come to you in infancy and we are monitoring IgG, because here IgM is not going to help you. So the rising titer is already documented. So remember one thing, a child can be treated for 1 year post your diagnosis. Okay, that is one thing. And second is the drugs. So here also we are giving pyrimethamine, sulfadiazine and leucovorin, because this is for the infection per se, right? Here pyrimethamine is not going to play any role. So pyrimethamine, you can give it in a dosage of 2 milligram per kg per day. This is the loading dose which has to be given only for 2 days. This is very important and you need to remember this. Following that, we have a we are not giving the loading dose, but we have given, it's still a high dose which is to be given for at least 2 to 6 months depending on the titers, and then we start a maintenance therapy, because I told you that the treatment has to be given for a complete of 1 year. Okay, so then the dosage will be 1 milligram per kg, but this is to be given only for thrice a week. And whenever you are giving pyrimethamine, don't forget to give leucovorin, because for the rescue therapy. Okay, and the second is sulfadiazine, which is given per orally, 100 milligram per kg per day in 2 divided doses. So that's quite simple. That makes it very simple. Now I believe that if any MCQ has been asked, will be asked on this particular topic, you'll be able to solve it. Okay, now let's do some interesting MCQs. So risk of transplacental transmission of Toxoplasma gondii is maximum when the mother is infected prior to conception, during first trimester, during second trimester and during the third trimester. Yes, Dr. Srinu and Dr. Rahul, can you just try to answer this particular question? It's very simple. We have already discussed this. The risk of transplacental transmission of Toxoplasma gondii is maximum. So we saw those percentages in the beginning of the lecture. So try to remember those percentages and solve this. Yes, anybody? Okay, so we saw that during the third trimester, there is a 65% chance, right? So the answer is D, that is during third trimester. Interesting and simple, right? Okay, one more very simple question. A pregnant lady had no complaint but mild cervical lymphadenopathy in first trimester. She was prescribed pyrimethamine but was non-compliant. Baby was born with hydrocephalus and intracerebral calcification. Which of this is likely cause? So the answer is rubella, toxoplasma, CMV and herpes. Yes, very good, Nikhil. Your previous answer was absolutely correct. That is the third trimester. Now, if you could try solving this particular question. Very interesting question. You have got 3 clues over here. First is the mild cervical lymphadenopathy. I told you in the beginning that this condition can present only as lymphadenopathy. The second clue over here is giving pyrimethamine to the mother, and the third clue over here is the child born with hydrocephalus and calcification. So we saw the triad already. So very good, Nikhil. The answer is B, that is toxoplasmosis. Very well answered. Actually, why this explanation? Because you know, when we are already handling 300 MCQs during your exams, it often happens that we are not able to pick up the pointers, and that's the reason why it's preferable to have some technique of learning. Like I showed you the cat faces to remember the triad of toxoplasmosis, so you can use such methods to remember all these confusing cases. Okay, now this one. Congenital toxoplasmosis falls is diagnosed by detection of IgM in the cord blood. IgA is more sensitive than IgM for detection. Dye test is gold standard for IgG, and avidity testing must be done to differentiate IgA and IgM. Very obvious question. Little bit of a difficulty level is little bit moderate to higher difficulty. Try solving this. I do agree that this is a bit of a difficult question, but not an impossible question. Yes, Nikhil. Okay. See, the answer here is actually D, because D option is quite, for that you need to know what is avidity testing. Actually, avidity testing is associated with IgG antibodies. Okay, the affinity of the IgG antibodies to the viruses. I'll quickly show you what is avidity testing. Let us see the other options. Actually, all the other options are correct over here. And it is also true that IgA is more sensitive than IgM for detection. That is first thing. And rest is like diagnosed by detection of IgM in the cord blood. That is also true. And diet test is gold standard for IgG. That is also true. Now quickly I would like to show you what is avidity testing. Okay, before I end this today's session. Yeah, so this is avidity testing basically, which we do most commonly for the cytomegalovirus infections. What is it? It is the functional affinity of the IgG antibody in response to the infection. Okay, the maturation also, just I would advise you to write it down quickly because this is important. And the maturation of antibody avidity over time can be used to discriminate between primary or acute and non-primary or remote infection. Very self-explanatory. And coming to this, the determination, that is low avidity means there is a primary or acute infection, and high avidity means a remote infection. This makes the explanation even more clear and simple. That is, IgG avidity assays measures the binding strength of the IgG antibodies with the virus. So that is the introduction which I gave you. It helps to diagnose a primary cytomegalovirus. So this we are doing for primarily for the cytomegalovirus infection and not for toxo. And second, it has nothing to do with IgA or IgM. So that was the option, right? So here what it is related to the IgG antibodies and the viruses. So that is one important thing. Following primary cytomegalovirus infection, so IgG antibodies have low binding strength, that is low avidity. Then over the next 2 to 4 months mature to high binding strength, that is high avidity. Okay, so I think now today you have learned two things. You have learned something about toxo, which is a very important topic. Some recently asked MCQ, so they were from AIMS and PGI question. I could find these three from the recent. Rest, some remotely asked MCQs I had already included in the literature and have already focused on that while teaching. Okay, so just remember the cat faces. Okay, the simple, that is toxo. You join T and P of toxo. So you just join the T and P of toxo, that makes a huge face, right? So and then the plasma, so plasmosis, that M becomes the ear. So this looks like a cat plus some hair over here. Okay, so this is like the chorioretinitis or eyes, right? And this is huge head, that is hydrocephalus, and these are the intracranial calcifications. Okay, so that is the way to remember this. Similarly, I have many mnemonics to remember cytomegalovirus, mnemonics to remember rubella, like the blue bella. Blue bella is a very cute mnemonic for rubella infection. So this I will be discussing tomorrow. Okay, so tomorrow we'll be discussing rubella, so that these short topics are going to make things very easy for you, easy to grasp and easy to remember, as well as easy to recapitulate during your exams. So thank you very much. I'll end my session over here. Thanks Nikhil and Barwala, Rahul and Dr. Shrinu. I hope I didn't miss out Dr. Rahul and Dr. Shrinu, because I think there was some disturbances in the mid of the session. So the net coverage was a issue. Okay, so tomorrow same time at 7:30 I'll be discussing about rubella. Very simple way to remember entire rubella. Okay, and plus some interesting MCQs on that as well. So have a good day and see you back tomorrow. I end my session over here. Bye bye.